Namaskar. Welcome to all our very beloved delegates and distinguished faculty for the second day at the Windows Initiative brought to you by Divas and Artists. We, with the lighting of the lamp, from darkness to light, from ignorance to knowledge, certainly believe that we have gotten better today than yesterday, thanks to the wonderful deliberations that we had, giving us very many new insights into what we had been thinking about, but has truly opened some of the windows and helped us look far ahead with both the short term and the long term solutions that we could offer to make this world a better place. So this slide has many hearts there because Usha and me offer a heartfelt thank you faculty from right across the globe who have shown us the spirit that though some of them were to discuss and deliberate today, they were with us through and through the whole of yesterday's session and 5 hours of togetherness with the knowledge share, with a brilliant exchange of thoughts and ideas for helping us pave the way forward is indeed something that Usha and I, Divas and artists, have to be grateful for. Today in India, we are celebrating the National Girl Child's Day. And why a special note for the girl child? Yes, ladies and gentlemen, we need to look at some of the social context and view most of these problems through the gender lens as well. It's not only the knowledge and the technicalities and the awareness and the accessibility, but there is something which is unsaid and hidden beneath what appears to be a simple problem to solve. So we need to think stronger and deeper. Let us first have some reflections and recap of what we did yesterday. And to present that to you, we have Dr. Chitra Selvan. May I request Dr. Usha Sriram to kindly introduce our dear, the next generation, Chitra Selvan.
Thank you, Hema. And I want to join you in again thanking everyone who did such a brilliant job yesterday. The feedback has been so uniformly amazing and positive. And for thank you to all of the faculty who joined yesterday, though they were speaking, today. And such a pleasure for me to introduce Dr. Chitra Selvan, a young endocrinologist, professor of endocrinology at MS Ramaya Hospital, Bangalore, consultant endocrinologist at MS Ramaya Hospital. She has big areas of interest in women and diabetes, language matters in diabetes, weight management and obesity, and polycystic ovary syndrome. But I really just want to say something. Chitra is the perfect amalgam of drive and passion and the right disposition, and most importantly, the smarts. So I'm just so thrilled to welcome her to this program, and she's going to give us a recap of yesterday. Welcome, Chitra.
Thank you so much, Dr. Usha Sriram. That is the kindest introduction I've ever had the privilege to listen to. Thank you, Dr. Hema Diwakar, for bringing us on to this session. And what an honor it is to share the learnings of yesterday with this audience, because it was a day of such intense learning yesterday. Just one small glitch there.
Dr. Chitra, you have to unmute.
Unmute yourself.
Yes. Perfect.
Kindly share your slides.
Yes, yes. I'm just trying to do the same. Zoom is, yeah, not allowing me to share slides just now. Yeah, doing it now. All right. So sorry about that glitch. Jumping right into this. It was such a day of amazing deliberations, and I think that is the biggest advantage of having multidisciplinary conversations, because we are all in our specific silos doing what we know best without learning about the advances which happen in all other silos, and no specific area like pregnancy and women's health, where there is an absolute requirement for all of us to come together. And what a fantastic program put together by Dr. Usha Sriram and Dr. Hema Diwakar, endorsed by all the big collaboration of doctors, FIGO to Royal College of Obstetricians and Gynaecologists and the Endocrine Society of India, to bring together this platform for a intense learning session which happened yesterday. So we had two sessions which happened yesterday. The first session was getting ourselves introduced to the idea about how pregnancy can prove to be a window or a stress test or a peek into what the future of a woman's health might hold. And then we moved on to talk about hypertension and gestational hypertension, and a very interesting talk by Professor Baski Tilaganathan about identifying preeclampsia. And we finished off session one with Dr. Usha Sriram taking us through low birth weight babies and the metabolic problems that ensues for that particular child. I'm going to now break into each of these talks to spend about a minute to highlight the specific points which were made. So the first talk was about how pregnancy is a stress test can to uncover non-communicable diseases that we could be predisposed to, and how it can also turn out to be a window where we can make changes to alter the blueprint of that woman's health. So we started out by acknowledging that non-communicable diseases are a major cause of mortality in women, not just in developed countries, but also in low and middle income countries. We then went on to talk about that gestational hypertension, and in particular preeclampsia, increases risk of future non-communicable diseases. And we also went on to learn that much of this could be addressed and maternal mortality could be reduced if we target specific issues like hypertension in pregnancy. We also paused and to reflect on anemia in pregnancy, which Professor Amanda Henry was very, very right in pointing out, does contribute to worse pregnancy outcomes. And it is very common in lower and middle income countries. We know that up to 50% of pregnancy can be complicated by anemia, but it's not uncommon even in the higher income countries. That's something that we did speak about. But probably the most important point, which I took away from Professor Amanda Henry's talk, was that literally every pregnant woman across the globe accesses healthcare facility at least once during their pregnancy. Some pregnancies may even come in for 3 to 4 visits. And I think that is the biggest advantage of looking at pregnancy as a window to alter health outcomes for the rest of their life. And we did speak about how long-term issues prevention can be done at this window. And she did speak about how you might be at risk for future NCDs, but that does not mean that's your destiny. We can make changes to alter it. So we ended on that high note of a call for action. Almost all talks yesterday ended on the high note of call for action. And that was Professor Amanda Henry for us, presenting the peek into why pregnancy is a stress test for the future. Then we had energetic Dr. Amy Sharma take us through specifically hypertension and gestational hypertension in pregnancy. She brought to light that up to 15% of pregnant women experience hypertensive disorder of pregnancy, and about up to 7.5% have preeclampsia. And what was important to note was that while we traditionally tend to believe that hypertension is probably more common in older women, she was right in pointing out that the prevalence seems to be rising in younger mothers, probably attributable to the fact that more and more mothers are entering pregnancy with pre-existing obesity and probably undetected hypertension as well. So that was something new that I learned. And also, she went on to show that mortality can be significantly reduced by targeting just hypertensive disorders in pregnancy. So that is something we should watch out for and be absolutely to ready. And she did point out that how very simple low risk interventions like exercise or increasing the number of steps or walking during pregnancy could go a long way in bringing down the burden of hypertension and gestational hypertension in a pregnancy. And of course, we know that postpartum turnouts for follow up clinics are very poor, quite understandably, especially in mothers who've just given birth to a newborn that they have to care for. But I think what we've learned and adapted to in times of COVID is that remote consultations and virtual consultations can work out just as well. And she did show us data that when people had to log in their home monitoring of blood pressure readings virtually, the amount of people logging in their readings were much, much higher. So there was a very simple and important lesson for us that maybe just a message or a phone call to get them to log in their readings could be the way we can improve outcomes related to hypertension post delivery. And another extremely important point that she made was about the ASCVD risk calculation for women specifically, and about how including the component of whether there was preeclampsia in the mother or not during her pregnancy could more accurately predict that particular woman's risk for future NCDs and cardiovascular disease, especially in women aged between 40 to 49 years. So there were many, many learning points for me. But one of the things that Dr. Amy Sharma also said was it's enough of appreciating and acknowledging the beauty of the pathophysiology and important to now try and stop it or put brakes onto it. So that was Dr. Amy Sharma, fantastic session on hypertension and gestational hypertension. Then we moved on to another extremely intriguing session on prediction and prevention of preeclampsia by Professor Baski Tilaganathan. So he did tell us that we are all aware of what we've traditionally identified as risk factors for preeclampsia. It's a checklist of women more than 40 years, women belonging to Blacks or other minorities, women with a BMI which is high, or a past history of preeclampsia. While the checklist works very well, it might in some way be ineffective and might also stigmatize women. Although we might not be actually bringing down the risk of preeclampsia or improving outcomes for mothers. So he went on to suggest that very, very early in pregnancy, alterations in uterine blood flow could potentially serve as markers for preeclampsia. I might not have understood the nuances of all of the uterine blood flow parameter changes, but I did get to understand that certain aspects of these measurements could provide huge, huge clues as to which mothers are predisposed to develop preeclampsia in future pregnancy if you do this study in early pregnancy. So he went on to demonstrate evidence which looked at an algorithm which is based on factoring some parameters which looked at uterine blood flow along with some other traditional risk factors like age and BMI, and used this to identify high risk women. And what happened then was utilization of this algorithm was able to pick up with a greater specificity women who were predisposed to preeclampsia. And the ASPIRE study, which studied aspirin prophylaxis in preeclampsia, did use data from one of these algorithms and showed that utilization of aspirin starting much earlier than what we regularly and routinely do managed to delay the onset of preeclampsia by 2 weeks. That's 2 crucial weeks during gestation, which could improve outcomes for the baby and also for the pregnancy, also for the a fetus who's born after that pregnancy. It was also important to note that there was 30% resistance to aspirin when used at the dose of 81 milligrams, about 5% at 160 milligrams. That is a much higher resistance of aspirin than I was aware of. And then he went on to show exciting data from his clinic about how they took this bit of information from the algorithm and the Aspire study and implemented in their clinical practice, targeting women between 11 to 13 weeks, used the algorithm, gave them 150 milligrams of aspirin, and followed them up through pregnancy. And they did see a 23% reduction in preeclampsia with improved compliance, because here you had managed to convince the mother who's sitting across your table that you used an algorithm to tell that particular woman her specific risk instead of a blanket umbrella statement saying you need to go on aspirin because you're Asian Indian. So it also managed to translate into improved fetal outcomes because there was a 40% reduction in small for gestational age. This was exciting a work presented by Professor Baski Tilaganathan that we had the honor to listen to yesterday. Then we had Dr. Usha Sriram talk about small babies and the big metabolic consequences that happen because of small babies. We know that prevalence of low birth weight babies is high, pitted anywhere around 20% across the globe. But Dr. Usha Shriram also highlighted that up to 42% of mothers in India are underweight. So while we grapple with rising obesity, it's also important to acknowledge that malnourishment and underweight is very common in India. Dr. Usha did highlight certain very specific contributors to metabolic health, which is exposure to air pollution in the form of the air pollution that you're exposed to while you're cooking using firewood. Also, the effect of stress on pregnancy and adverse outcomes. We did spend some time reflecting upon the mechanisms of these changes by talking about Barker's hypothesis and about how the time that you spend in the womb is probably the most important bit of investment in health that you can actually do to make sure that health in the rest of your lifetime is healthy. She did highlight the golden window of 1,000 days starting pre-pregnancy to about 2 years after the child is born itself. She did highlight that small babies are at increased risk for obesity, diabetes, and CVD, and that we know. But it also means there is increased mortality at a much younger age and also lower mental health and abilities. So she did highlight that small for gestational babies are particularly predisposed to postpartum excessive nutrition by over-enthusiastic grandparents and parents. So that's something we should probably bear in mind and maybe have a word with. But my biggest takeaway was that the 1,000 days window where you can actually change the metabolic blueprint of babies to be born, targeting from pre-pregnancy to the first 2 years of life. And that was Dr. Usha Sriram at the end of session 1. We took a short break and then we came back with our cups of coffee for the second session, which was on pregnancy, obesity, macrosomia, and more. And we began with a talk by Professor Donna Ryan on obesity in women of reproductive age. She did warn us that India is probably at the threshold of a rise in obesity, which is quite scary. We are currently at about 8 to 12%, some studies showing up to 30%. But it's important to note that most women across the globe gain more than 1 point of BMI in their reproductive years, and that marriage and pregnancy are two important drivers or pit stops which drive up this weight gain. And post pregnancy, there's at least a gain, an average of 1 kilo is what she pointed out, but I'm sure the mean is much higher, at least in urban India. And that obesity is a complex condition, and that it's not just about calories in and calories out and calorie deficits, that our hypothalamus and our body will defend the highest fat mass that we are at, and that makes why weight loss that much more difficult. So we did also address that removing stigma from our conversations, making obesity a chronic condition for which they must be at continued care under physicians, prioritizing maternal health, addressing social inequalities which predispose to obesity in women were all factors that she spoke about, and also called for making obesity as part of a comprehensive universal health package globally. So that was Professor Donna Ryan on obesity and reproductive health. And then we had Professor Redman talk to us about gestational weight gain, exploring the science, concerns, and solutions. We started out by acknowledging that up to two-thirds of women entering pregnancy were overweight or obese. Uh, and of course that there is a transgenerational transmission of obesity. So if you have a mother who enters pregnancy obese and also gains more weight during gestation than recommended, it leads to the children being born large for gestational age or having macrosomic with a predisposition to obesity in early childhood. And Dr. Usha Sriram did highlight that obese children are likely to track their BMI and end up as obese adults. And that's exactly why Professor Redmond's talk connects right back to where Usha Sriram left us off. And she did talk about the Institute of Medicine recommendations for weight gain. So, if a woman is in the normal BMI range, it's recommended that she gains about 11 to 13 kgs in that pregnancy. And if you're overweight, you're not likely or should not be gaining more than 5 to 9 kgs of weight during pregnancy. But she also showed us evidence to suggest that most women were gaining more than the recommendation for their BMI. And she went on to show that the Fit for Delivery study, which was an intervention study to look for gestational weight gain during pregnancy with interventions involving both food and exercise to target gestational weight gain, showed that it seemed to work for normal weight women, but it did not work so much for obese women. So the conclusion of the study was that most interventions which are done during gestation might not really work. But Professor Redman jumped right on to make a more nuanced understanding of the situation. And she went on to present some amazing data from her lab to show that to for any intervention to show any benefit, that you have to document a 200 kilocalories per day deficit to prevent the recommended weight gain excess that happens during pregnancy. So once she got hold of this magic number of 200 kilocalories per day for the intervention to be effective, she went on then and looked at all the studies which deemed all of these interventions as a failure, and saw that many of those studies were not creating this 200 kilocal per day deficit. She went on then to present data to start, which started early, and an intervention which created 200 kilocals per day deficit. And she did demonstrate that not only did it mean improved pregnancy outcomes, but also improved fetal outcomes. Exciting work. And I think this highlights why it's important to bring women into the field of women's health, because I'm not sure too many people would have wanted to peer into this and figure out the problem and find a solution and implement it and demonstrate change. Goosebump inducing work by Professor Redmond's lab. Thoroughly enjoyed her talk. And then we had Professor Ronald Ma, whom we've had the privilege of listening to many times in Dr. Usha Sriram's meeting. But what he presented yesterday was again such important information. Yes, we're all aware that of the Pedersen's hypothesis that if you have maternal hypoglycemia, which is uncorrected, it leads to obesity in the fetus, which could potentially increase cardiovascular risk and increase predisposition to diabetes and hypertension at childhood itself. But all of us, maybe from the time that we've had the GDM diagnostic criteria being changed maybe about a decade ago to the new criteria, which is more stringent, do once in a while pause to wonder, isn't this too stringent? Are we making pregnancies more and more medicalized? That's something that does cross our minds. And he presented exciting data about the follow-up data of the HAPO study. So his center was one of the centers for HAPO study, and he presented the Hong Kong cohort data, which showed that in the children were found to have GDM according to the new criteria, even at 8 years of age, there was a higher risk of blood glucose levels and increased systolic blood pressure. And then he went on to show that the actual core group of HAPO itself managed to recruit 10 centers out of the 15 original centers for HAPO for follow-up. And now they have data which they've published at the end of 7 years to suggest that at the new diagnostic criteria, the fetus born with uncontrolled blood sugars did have higher prevalence of obesity, higher OGTT, and higher blood pressure. He did make a very interesting point about classifying GDM as subtypes, as predominant insulin resistant versus predominant beta cell dysfunction, and spoke about probably we should be designing interventions which are specific to the subtypes of GDM to probably reap better outcomes. And he did present data on how interventions postpartum to GDM mothers should be implemented. He presented data about how intensive breastfeeding could bring down risk of future diabetes, how targeting gestational weight gain could be a way in to bring down the prevalence of GDM. Targeting mothers who've had a past history of GDM is such a gold mine of a patient cohort whom we should be targeting to prevent the risks of type 2 diabetes. Extremely new, interesting data by Professor Ronalma from the HAPO group and more. And we then had an extremely light-hearted, brilliant, practical discussion on pre-pregnancy counseling by Dr. Geeta Arjun and Dr. Ambrish Mittal, moderated by Dr. Usha Sriram and Dr. Hema Diwakar. We spoke about so many small points: how to get them to move more, how to increase protein in your diet, how to bring up the conversation, how to drop words like obese or morbid obese in your clinic, and how to begin with positive reinforcement of everything that you're doing right. And the nugget of a pearl from Dr. Geeta Arjun saying that the only 5 things that you need to look at is hemoglobin, TSH, fasting plasma glucose, weight, waist circumference, and a blood pressure medication. So that was a recap of the first day of intense learning, and I cannot wait to begin the second day of learning. Thank you so much for giving this opportunity for me to share my learnings from the first day.
Thank you,